Talk on induction and augmentation of labor. What is induction of labor? It is the artificial stimulation of uterine contractions before the onset of labor beyond the period of fetal viability, whereas augmentation refers to the stimulation of spontaneous contractions that are considered inadequate because of failed cervical dilatation and fetal descent. The goal of induction of labor is to eliminate the potential risk to the fetus with prolonged intrauterine existence while minimizing the likelihood of operative delivery. What are the WHO recommendations for induction of labor? It should be performed only when there is a clear medical indication for it and the expected benefits outweigh its potential harms. While considering induction of labor, we should give importance to the actual condition, wishes and preference of each woman, and emphasis is laid on the cervical status, the method of induction, and the associated conditions such as parity and rupture of membrane. Induction of labor should be performed with caution because the procedure carries the risk of uterine hyperstimulation, rupture, and fetal distress. Whenever it is carried out, there should be facilities for assessing the maternal and the fetal well-being and also for performing caesarean section if needed. Women receiving oxytocin, misoprostol, or other prostaglandins should never be left unattended. Coming to the indications of induction. So we have certain maternal diseases like hypertensive disorders of pregnancy, diabetes, renal disease, chronic pulmonary disease, and premature rupture of membranes, chorioamnionitis, fetal growth restriction, Rh isoimmunization, postdated pregnancy, fetal demise, abruptio placentae, and fetal malformations incompatible with life. Also, certain logistic factors may need to be considered, like if there is a risk of rapid labor, the patient stays at a place which is at a distance from the hospital, or psychosocial indications. Now, there are certain absolute contraindications to the induction of labor, such as major degree of placenta previa, vasa previa, previous classical uterine incision or incision because of metroplasty or extensive myomectomy, particularly in cases where the uterine cavity has been opened. Encephalopelvic disproportion, active genital herpes infection, invasive carcinoma of the cervix, and transverse lie. Then there are some relative contraindications where induction may be performed but with caution, such as in multiple pregnancy, polyhydramnios, grand multiparity, maternal heart disease, severe hypertension, breech presentation, one or more previous caesarean section, abnormal fetal heart rate, and presence of cervical fibroid. Evaluations to be done before planning induction of labor. So for the mother, we should have a confirmed indication for induction of labor. Review presence of any contraindications. Perform clinical pelvimetry to assess the shape of the pelvis and adequacy of the bony pelvis. Next is to assess the condition of the cervix and to assign the proper Bishop score. Then review the risk, benefits and alternatives of induction of labor with the patient. For the fetus, confirmation of the gestational age. We may need to document fetal lung maturity status in some cases and estimate the fetal weight, determine the fetal lie and presentation, and confirm fetal well-being. According to the ACOG committee opinion, fetal maturity may be assumed if fetal heart tones have been documented for 20 weeks by fetoscope or for 30 weeks by Doppler, or it has been 36 weeks since a positive urine HCG test, or an ultrasound measurement of the crown rump length obtained at 6 to 11 weeks supports a gestational age of 39 weeks or more. What is failure of induction? It is defined if the cervix fails to dilate up to 3 to 4 cm within 24 hours of induction. Our options here may be to wait if there is no rupture of membrane and postponement is not harmful for the fetus as well as the mother. But if there is any urgency, then caesarean section has to be performed. Labor monitoring. During induction, we have to monitor the uterine activity and also the fetal heart rate. In case of clinical auscultation, the fetal heart rate should be heard during and for 30 seconds after a contraction, at least every 15 minutes during the active phase of labor, and after every contraction in the second stage. Electronic fetal monitoring is preferable. Partogram is to be maintained for active labor. It should be done by trained personnel in a well-equipped center. Nowadays, monitoring of uterine contractions by measuring the intrauterine pressures is also done in some centers. And for fetal monitoring, we may opt for fetal pulse oximetry, fetal electrocardiogram, waveform analysis, intermittent measurement of lactate by fetal blood sampling as an adjuvant to electronic fetal monitoring. Risk of induction of labor. What are the maternal risks? It may lead to failure leading to caesarean section. The risk is 2 to 3-fold, especially in nulliparous lady. Then risk of hyperstimulation, rupture uterus, intrauterine infections like chorioamnionitis, amniotic fluid embolism, risk of having precipitate labor or dysfunctional labor, risk of postpartum hemorrhage that is particularly atonic, then abruptio placentae, and sometimes antepartum hemorrhage resulting from undiagnosed placenta previa, and water intoxication, particularly in case of high oxytocin dosage use. What are the fetal risks? Risk of fetal distress, fetal death, neonatal sepsis, iatrogenic delivery of a preterm infant, cord prolapse, neonatal jaundice, and risk of birth trauma. Pre-induction cervical assessment. Now, success of labor induction is closely related to the ripeness of the cervix. Various scores have been proposed to evaluate the cervical status. Bishop's score, proposed in 1964, takes into consideration the cervical dilatation, effacement, position, and consistency, along with the station of the fetal head. Burnett later on modified the original Bishop score. He considered effacement in terms of length and not percentage, and considered previous term birth and cephalic presentation to be prerequisites for induction. Outcome of patients with a lower score was unfavorable. Evaluating the performance of Bishop score, Lang et al. Observed that cervical dilatation was twice as important as the other factors and proposed a modification of the original score which predicted successful induction equally well. What are the predictive factors for successful induction of labor? When the period of gestation is higher pre-induction score, increased sensitivity of the uterus, presence of fetal fibronectin in vaginal swab, maternal height more than 5 inch, normal BMI, estimated fetal weight less than 3 kg. What do we mean by cervical ripening? It is a prelude to the onset of labor where the cervix becomes soft and compliant. The cervix is a complex and heterogeneous organ that undergoes extensive changes throughout gestation and parturition. This remodeling process is extremely complex and it involves properly timed biochemical cascades, interaction between cellular and extracellular components, and infiltration by inflammatory cells. Cytokines like interleukin-1 beta enhance the activity of collagenesis and interleukin-8, then platelet activating factor, monocyte chemotactic factor 1. Estrogens increases collagenase whereas progesterones inhibit collagenase, hyaluronic acid and interleukin 8. Nitric oxide stimulates leukocyte infiltration and induces prostaglandin secretion. Methods of cervical ripening and labor induction. Cervical priming before labor induction in an unfavorable cervix increases the success rates and also shortens the induction to delivery interval. Methods for cervical ripening and labor induction can be broadly classified as pharmacological methods such as use of prostaglandins, oxytocin and others, and non-pharmacological methods which may be natural methods, surgical methods, mechanical and others. So we begin with the pharmacological methods. The first is prostaglandins. The chemical precursor is arachidonic acid. Prostaglandins are endogenous compounds found in the myometrium, decidua and fetal membranes during pregnancy. Cervical production of prostaglandin E2, then prostaglandin I2 also known as prostacyclin, and prostaglandin F increases at term pregnancy. What are the mechanisms of prostaglandin action? It causes dissolution of collagen bundles and an increase in submucosal water content of the cervix by an alteration of the extracellular ground substance of cervix by increasing the collagenase, elastase, glycosaminoglycans, dermatan sulfate and hyaluronic acid levels. It also causes relaxation of the smooth muscles of the cervix, facilitating its dilatation. Next, it also helps in the initiation of the uterine contractions by gap junction formation and increase in intracellular calcium levels. Thus, prostaglandins have action both on the cervix and on the uterine myometrium. Intracervical prostaglandin E2 gel, which contains 0.5 mg of prostaglandin E2, is used. A maximum of 3 insertions are allowed over 24 hours. If required, oxytocin is to be used only after 6 to 12 hours of the last insertion. Then we may also use intravaginal prostaglandin E2 gel, which contains 2.5 mg prostaglandin E2. 2 doses are used 6 hours apart. Then we may use vaginal control release insert, which are 10 mg tablets releasing 0.3 mg per hour of the prostaglandin. The fetal heart rate and uterine activity should be monitored for 30 minutes to 2 hours after the instillation. The control release insert should be removed at the onset of labor. Vaginal route, either gel or insert, is superior to intracervical route for cervical ripening as they are equally effective and less invasive. Control release in vaginal insert use gives a better post-ripening score. It decreases the time to delivery, time to active labor and also need for oxytocin use and are cheaper. The overall incidence of hyperstimulation is 4.8%, almost same as like with oxytocin. Contraindications for prostaglandin E2 use. Established uterine activity, then glaucoma, presence of asthma, severe hepatic or renal impairment or known hypersensitivity to prostaglandins or active vaginal bleeding. Side effects are, it may lead to uterine tachysystole, fetal distress, and sometimes there may be systemic effects like nausea, vomiting and diarrhea. Next we come to misoprostol, which is a synthetic prostaglandin E1 analog. This is a cheap drug. It does not require storage conditions. Can be given by oral, buccal or vaginal routes. Although the vaginal route is the most extensively used. Oral route is not recommended at this point of time. Peak levels with vaginal administration are attained more slowly and sustained for longer periods because of the pre-systemic GI and hepatic metabolism that occurs with the oral route. The systemic bioavailability is 3 times higher with the vaginal route. It is deesterified to prostaglandin F analogs. Half-life is 20 to 40 minutes. Excretion is mainly renal, that is 80%, and the remaining is fecal. Side effects include tachysystole, meconium passage, and uterine rupture. As per the ACOG guidelines, 25 microgram should be the initial dose for labor induction at term and should be administered not more frequently than 3 to 6 hourly. Maximum 6 doses should be used. Oxytocin should not be administered less than 4 hours after the last misoprostol use. It should be avoided in patients with previous caesarean delivery or major uterine surgery. Use of higher doses, that is 50 microgram, may be appropriate in some situations and have a greater likelihood of vaginal delivery within 12 hours, but it increases the risk of hyperstimulation and rupture uterus. At present, there is insufficient clinical evidence to address the safety of misoprostol in patients with multiple pregnancy and suspected fetal macrosomia. What does the RCOG guidelines say? Misoprostol appears to be more effective than either oxytocin or vaginal prostaglandin E2 in presence of ruptured membranes for induction of labor. Use in obstetrics should be restricted to randomized controlled trials. Oral misoprostol appears to be less effective than the vaginal form, associated with less incidence of uterine hypercontractility. Vaginal use, although it is associated with increased uterine hypercontractility, but it is not translated in increased operative delivery. Despite a lot of clinical use, misoprostol is still not approved by the Drug Controller of India for use in induction of labor because of safety concerns. Next, we come to oxytocin. This is a nonapeptide which is synthesized in the supraoptic and periventricular nuclei of the hypothalamus and secreted by the posterior pituitary gland. It is a potent uterotonic agent that can be administered by any parenteral route, IV route being the most widely used. Half-life is 3 to 5 minutes. Once absorbed, it is distributed in the extracellular fluid and does not bind to plasma proteins. It is excreted by the liver and the kidneys. It is rapidly metabolized and degraded by oxytocinase. The action is mediated by oxytocin receptors present on the myometrium. Myometrial response to oxytocin begins at 20 weeks, increases throughout pregnancy and peaks just before the initiation of labor. The response varies according to the status of the cervix, then the uterine sensitivity, variability in oxytocin clearance rate, duration of pregnancy, and the pre-existing myometrial contractions. Myometrial oxytocin receptor concentration increases 100 to 200 fold during labor. The OTR concentration is the rate limiting step for oxytocin action. Oxytocin binds to the OTR, increases the intracellular concentration of calcium, leading to myometrial cell contraction. It also stimulates amniotic and residual prostaglandin production. It has been postulated that prostaglandin released by oxytocin is necessary for fully efficient uterine contractions during labor. The contractions which occur are physiological. That is, it causes fundal contraction with relaxation of the cervix. Oxytocin should be started with a low dose and then it is escalated at an interval of 20 to 30 minutes if there is no response. When the optimal response is received, that is uterine contraction sustained for about 45 seconds and numbering around 3 contractions in 10 minutes, then that particular concentration of the drug in milliunits per minute is to be continued. This is called oxytocin titration technique. The objective is not only to initiate uterine contractions but also to maintain the normal pattern of uterine activity till delivery and at least 30 to 60 minutes beyond that. The incremental increase is reduced in presence of hyperstimulation. RCOG says that oxytocin should not be started for 6 hours following administration of vaginal prostaglandins. In women with intact membranes, if feasible, amniotomy should be performed prior to commencement of oxytocin infusion. The minimum possible dose should be used and then titrated against uterine contractions. Risk of oxytocin use. It may lead to hyperstimulation with or without fetal heart rate changes. There may be failed induction with need either for repeat induction or caesarean section. Risk of uterine rupture, hypotension if administered by IV bolus, then hyponatremia if it is administered with large amounts of sodium poor fluids. Then it may have antidiuretic hormone-like effect, that is water intoxication if it is administered at high doses. Then there is risk of neonatal hyperbilirubinemia. Contraindications: if there is unfavorable fetal position, then uterine tachysystole, hypersensitivity to oxytocin, and cases where vaginal delivery is contraindicated. Coming to other pharmacological methods. Mifepristone 200 mg for 2 days has been used recently, but the method is not cost effective and further trial is required. Relaxin has been demonstrated to cause changes in the collagen, resulting in cervical softening. Cytokines may also promote cervical ripening by causing changes in the extracellular matrix. Natural modalities include herbal supplements like evening primrose oil, black cohosh, and raspberry leaves. Then sexual intercourse. Then amniotomy. This is a surgical method of induction. The effectiveness depends on the state of the cervix, station of the presenting part. The induction delivery interval is shorter when amniotomy is combined with oxytocin than when either method is used singly. Advantages of amniotomy are: it has got a high success rate. We get a chance to observe the amniotic fluid for blood or meconium. Then assess to use fetal scalp electrode or intrauterine pressure catheter, or for fetal scalp blood sampling. Limitations are: it cannot be employed in an unfavorable cervix. The cervix should be at least 1 finger dilated. Indications are: presence of abruptio placentae, polyhydramnios, preeclampsia or eclampsia. Contraindications include intrauterine fetal death, maternal HIV infection or active herpes infection, all of which has a risk of infection. Immediate beneficial effects of ARM are lowering of blood pressure in preeclampsia and eclampsia, relief of maternal distress in hydramnios, control of bleeding in antepartum hemorrhage, and relief of tension in abruptio placentae, along with the initiation of labor. Hazards include chance of umbilical cord prolapse, amnionitis, accidental injury to the placenta, cervix, uterus or fetal parts, and rarely there may be Leica-Remni embolism. Another surgical method is stripping of membranes, which acts by release of endogenous prostaglandins and mechanical dilatation. We have certain mechanical modalities like hygroscopic dilators. These are natural or synthetic rods inserted through the cervical os and left in situ for a particular time, wherein because of their osmotic properties they absorb the endocervical and local tissue fluids. This swelling causes a controlled dilatation of the cervix and also release of prostaglandins. Natural dilators are obtained from the seaweed Laminaria japonicum. We may use balloon devices like Foley's catheter or certain other designer balloon devices. There are certain miscellaneous agents like castor oil, acupuncture, and transcutaneous electric nerve stimulation. Induction of labor in some special circumstances. In a lady with a previous cesarean section, cervical ripening can be done with prostaglandin E2 gel, intracervical or intravaginal. However, misoprostol is not to be used. Oxytocin can be used in low doses but with close monitoring of uterine contractions and fetal heart rate, which should be preferably continuous electronic fetal monitoring. Next, in twin pregnancy, prostaglandin E2 gel, then oxytocin in low dose can be used, and also we may go for artificial rupture of membrane. In premature rupture of membrane, we may use prostaglandin E2 gel, misoprostol or oxytocin with close monitoring, particularly for hyperstimulation. In intrauterine fetal demise, oxytocin is effective if the pregnancy is near term with a favorable cervix. But if the cervix needs ripening and the pregnancy is remote for term, we should better use prostaglandins, either misoprostol or prostaglandin E2. What is uterine tachysystole? It is defined as presence of 6 contractions in a 10-minute period. Uterine hypotonus is a single contraction lasting more than 2 minutes. And uterine hyperstimulation is when either condition leads to a non-reassuring fetal heart rate pattern. Summary of evidence based on ACOG recommendations. So what is level A evidence? Women in whom induction of labor is indicated may be appropriately managed with either a low or high dose oxytocin regime. Prostaglandin E analogues are effective in promoting cervical ripening and inducing labor. Fetal heart rate and uterine activity should be continuously monitored from the time the prostaglandin E2 vaginal insert is placed until at least 15 minutes after it is removed. High-dose prostaglandin E2 vaginal suppositories may be used in the management of intrauterine fetal demise in the second trimester of pregnancy. Then, although the optimal dose and timing interval of misoprostol is unknown, lower dose, that is 25 micrograms every 3 to 6 hours, are effective for cervical ripening and induction of labor. These are the cases where we have got a strong evidence. Next is level B evidence, that is slightly weak evidence. Misoprostol use in women with prior cesarean birth should be avoided because of the possibility of uterine rupture. The use of higher doses of misoprostol, 50 micrograms 6 hourly to induce labor, may be appropriate in some situations, although there are reports of increased risk of complications like uterine hyperstimulation. Level C evidence for women with third trimester intrauterine fetal demises, intravaginal misoprostol can be used to induce labor. Fetal heart rate and uterine activity should be continuously monitored from 30 minutes to 2 hours after administration of PGE2 gel.